So what made you become a doctor, Dr. Ouellette?
Well, it's a story that goes back to my college years. I did go to college, as you well know, but on the other hand, had no idea of going into medicine. But during the summer vacations, I used to work in a hospital. See, my father, after the Depression, became, took a little while to find a job, but then he became an orderly in a hospital back in Fall River, Massachusetts. So during the summer, I used to work in a hospital with my dad, and when I went into medical school eventually, I used to spend my summers also in Fall River, and I got to work in a hospital again, but as a medical student. So I would help the doctors there at that point, doing physicals, histories and physicals, and then at that point, in the morning when there wasn't much to be done, I'd work in the operating room as an assistant. So I'd help the surgeons, they'd dress me up, and then I used to help the surgeons in their surgery. One day when I was doing this, there wasn't much going on in surgery. So one of the anesthesiologists who was there said to me, "Gee, if there's nothing, if you don't know what to do this morning, why don't you come with me and I'll show you what I do in anesthesia." So then I sat with him for the next several days, to say the least, and he was such a good instructor that he interested me very deeply. So therefore, when I continued on in medicine, I gave up the idea of going into ears, nose, and throat that had been in my mind all along, and I went into anesthesia.
What hospital was that you...
At St. Anne's Hospital in Fall River, Massachusetts.
So where did you graduate from medical school?
Well, I went to Laval University Medical School. See, the background that I had was that as I mentioned a moment ago, I was born in the Depression, and my father lost his job, and for 4 or 5 years we had very little to go by. At that point, as I grew up, we had very little because, as I said, he became an orderly in a hospital, which didn't pay much, and for the family that we had, we just didn't have much to go on. I did take a competitive examination when I was in the 8th grade, and I won an academic scholarship, and that paid me 60% of the cost of room, board, and tuition, all the way through into medical school, at which time I was also given a minimum of $2,000 a year to subsist and live while I was in medical school, and that, in those days, that was a lot of money.
Do you remember how much your med school costed?
Yes, about $12,000.
12,000.
Makes you laugh, doesn't it?
Yes.
Tuition was $12,000 at Laval University Medical School, where I went, which I attended in Quebec City, Canada. Now, you might want to say, why did you go to Canada? Well, when I got time to go to medical school, it was after the Korean War, and all the returning veterans were getting priority. Secondly, I still didn't have much in the way of financial support that was available through my family, because my dad was working at that time, not as an orderly, but as a stationary fireman in an orphanage back home in Fall River. So the funds were never very great. My folks never had a car until I finished medical school, and from that point of view, I learned the value of a dollar. But on the other hand, when I applied for medical school, I applied to the Canadian schools, which were accepted and recognized in the United States as Class A schools. So I was accepted at Laval, Montreal, and Toronto University. Why I chose Laval? Because I think it was probably the most economical one that I could find. So I went to Laval and they had a different schedule at Laval in the sense that we did our internship also before graduating. So I did my internship. It was a 5-year school. I did my internship in Canada and did some stages in Montreal and Quebec, and then returned back to the States, and I took up a residency at Springfield Hospital in Springfield, Massachusetts.
What year did you graduate again?
From what? From high school? From medical school, 1958.
So do you think the cost of your medical school influenced where or how you practiced medicine at first?
No, not really, because, you know, I was in a different situation than some others were probably than the American students who went to school here in this country. I, it was already prearranged that by the time I finished my anesthesia residency, that I would go back to my hometown. The anesthesiologists there who were practicing at that time, whom I had gotten to know very well when I was working in a hospital. You remember I told you that I was working there during the summer. Wanted me to go back there and work with them because there were two major hospitals in Fall River, or three at that time, St. Anne's, Union, and Truesdale. St. Anne's and Union were were covered by the same group by the same anesthesiologist. Truesdale was always a little bit different and had their own group. So that when I left, I went back to Fall River for 6 months, and I went to work with the two fellows who covered Union and St. Anne's. And there, at that point, things got a little bit different in the sense that the hospital at Truesdale, or Truesdale Hospital, lost their anesthesiologist, and they were looking for someone, so they asked me to cover. So I took over at Truesdale at the same time. So it was a real big beginning for me, from nothing to now working at 3 different hospitals and working day and night. I worked for 6 months at that time without a break, and I certainly had one heck of a nice beginning because at that time, you know, obviously, since I was doing all the work, I was getting I was being paid for that. We were on a fee-for-service, so that I was not covered by anyone. I was just earning what I worked for.
Just quickly back to medical school. Do you think that increased costs of medical school today influence the choices of young doctors after graduation or even before that, in terms of where, how many?
Probably, but not as much as it did maybe when I was when I started. The reason for that is that obviously there are people, there are young people whose families do not have the means. Obviously, that still exists, but the income earning capacity is much different than it is now. Now, the cost of medical school is much greater also than it ever was when I was there. But on the other hand, the financial help and assistance, and certainly the selection process is different than when I was there.
So, is there anything else that made you choose your specialty aside from working with the anesthesiologist at St. Anne's?
Not really. It was just something that I got to like very much. What my instructor at that time, my good friend, showed me, and I thought the idea was very appealing to me. So I just followed in that footstep. I did, as I told you, 2 years of residency at that time. 2 years was the minimum, was the required amount of time that you spent in your residency in anesthesia, which has changed after that. It's now 4 years, and I knew there were places for me ready to go to and work that I didn't have to wait. I didn't have to choose because, as I told you, they were waiting for me back in my hometown. I did go back there, and I worked there just for 6 months. And in between these 6 months that I was working there, I got a call from the chief of anesthesia here at St. Vincent Hospital in Worcester, and I came to Worcester in January 1st, 1960. Mainly because at that time my wife was due for another baby, and we didn't want to move until she had that baby, which came in the end of November. There's an interesting aside here that I may be jumping your questions a little bit, but you might say, how did you ever learn about St. Vincent?
Right.
Well, when I was a resident and when I was working in Fall River, particularly when I was a resident in Springfield, we had a little society called the Western Mass Society of Anesthesiologists. And as a resident, I was always invited to their meetings, and once a month we used to go to various hospitals, have dinner, and then sit there and discuss cases in anesthesia. And what happened is that I became very familiar and known to the anesthesiologists who were attending. So I got to know the people in Worcester, Massachusetts, and when I went to Fall River and they practiced there for a limited amount of time, they in turn remembered me, I guess, and called me in Fall River and asked if I'd like to come and join the group here in Worcester. And that's how I came to Worcester. However, I knew Worcester very well. let me just say that I went to prep school and college here in Worcester. I went to Assumption Prep, which is no longer in existence, and then Assumption College. And I had spent 8 years of my life here, and I like Worcester, contrary to Fall River, which I thought was very economically depressed and not very interesting when I was there, even though I was born in that city. I looked for the place to come to which had a good teaching program, and I could become involved in a limited amount of academia. I didn't want to go to a full-blown academia service, but I did like the idea of what they were offering here. So that's how come I came to Worcester.
So describe a typical day when you first started practicing here.
Well, I'll tell you, I joined a group. There were 3 people at St. Vincent at that time in anesthesia, and I was the 4th individual. And we were on call at that time every 3rd day or every 4th day, and we were covering the whole weekends from Friday to Monday morning. And one of the biggest episodes in my life was one weekend when I covered from Friday to Monday. I had something like 54 different surgical interventions that I gave anesthesia for. I had 2 sleepless nights, and I'll always remember that. That is no longer a problem in this country. Nobody works this amount of time in anesthesia. The groups have gotten much larger, and even without getting much larger, nobody would work this amount of time in anesthesia because it wasn't healthy. I mean, in the sense that, you know, I don't know how I made it. I was much younger, but I don't know how I made it through 2 nights without going to sleep, but I did.
So how did your typical day change over years of practice?
Well, it changed because of what happened eventually with my group in anesthesia. We were a group that eventually got to be 7 anesthesiologists at St. Vincent. And at that point, when the University of Massachusetts Medical School began to come into existence, I was involved with them. And I got to know the chief of surgery at St. Vincent, who eventually became the chief of surgery at UMass, Dr. Brownell Wheeler. At that point, when I was involved with, I got involved with Dr. Wheeler, I was asked if I would become chief of the group of anesthesiologists at St. Vincent. So I agreed to that, and I became chief, and I was chief for 12 years. During that 12 years, we got busier and busier. And eventually, I wanted to add, also became a corporation, by the way, financially. We became a corporation. I decided, and you know, we had sort of a democratically run group in the sense that everybody had the power to say what they thought and decide. And I felt that we should get more people than what we were at that time. The short and long of this is that I was outvoted, and nobody, and then we did not add anyone. During that time, the daily stress of running the group and trying to make everybody happy and dealing with problems, I had a health problem. And I had a couple of heart attacks, and I had a bypass. I decided at this point that this was enough for me, that I wanted to live a little bit longer, and I didn't want the stress, so I quit the corporation. And prior to that time, though, you know, we used to get these requests and consults for people who were in pain. And being a chief, I used to handle most of this because nobody else in the group wanted to take care of this. And I was interested in that. So that I did have an idea that I'd like this idea of continuing in here, but I told the administration at that time that unless it was done full time, that I would not want to do it part time. Right. So when I left the group, I went to the administration. I told them that I'd be willing to do this on a full-time basis and start a pain clinic. The administrator agreed with me. So we started a pain clinic at St. Vincent Hospital. There was no one, I had no patients. We advertised, we sent out notices to all the hospitals that we now had a functioning pain clinic, and they gave all the particulars. And I built it up over the next 13, 14 years to something over 3,000 visits a year. For the most part during those years, I was alone, except in the last part of those years. And then I had an assistant now and then. I had one for a little bit of period of time. Eventually, I got to the point where I got close to the age of 65, 66, and I said at 68 I quit. So I left the pain clinic in 1968, at which time the hospital continued the pain clinic, and now 3 people running the pain clinic at St. Vincent Hospital. So that it's a going concern, since it's the only one left in Worcester, and they're doing a very good job there. But it was interesting in the sense that I went from one type of operation, namely anesthesia, to the direct care of patient on a daily basis and dealing with their problems. Now that's a whole other ball game about what type of practice this was, because that entailed a whole different situation.
Well, let's talk a little more about your practice in anesthesiology, and then we'll get into that too.
Yeah.
Well, most of your patients were from around the Worcester area, right?
Oh yeah, Worcester and the surrounding areas, you know.
Did, no, I shouldn't have said. What do you think it was like for your family to have a physician in their household?
Well, they were very proud, as you can imagine. I was the first one to go through college in my family, never mind medical school or professional school, and I was obviously the first one and only one in my family that's ever been as far as I had gotten to. I do have a lot of children of my own who have gone through college and finished college and have become professional, but not in medicine. So that it was a source of pride for them, and the only thing I can say is that it was through their efforts that I got this far.
So, did you get to see your family often, or did your...
Well, this is a nice part about anesthesia. Anesthesia, contrary to general practice, I had definitive times. So I was at home at times that was predictable. I did have some nights on call, but those I knew about way ahead of time. So I always managed to get home to have dinner with my family. So my family and I grew up together, and that's something that you can't buy. Contrary to other colleagues that I know who are in other specialties, who could be called out any time of the day and night, who didn't have the family life in a sense that I had. In anesthesia, that was something that was a blessed gift in a sense, because I did see my family, they saw me, and the kids and I grew up together. They still ask me to play golf with them.
How has technology and anesthesia changed from the beginning of your practice?
Yeah, you have to remember now that I've been out of that. Not only have I been retired for this is my 5th year, but I was out of that for about 13, 14 years when I ran the pain clinic. Certainly, anesthesia has taken has gone under a vast improvement, particularly in the safety field. In a sense that, you know, as well as I do, that even at the time that I practiced, we were practicing with drugs that were highly inflammable, and you know, explosions did occur in the operating room, etc. Well, those things are not seen anymore. I mean, there's so many safety factors now involved in the practice of anesthesia as far as the technical aspect is concerned, that is a relatively safe practice. Now, as far as the drugs are concerned and the techniques, yeah, I mean, the techniques have marched along with medicine the same as medicine has marched along in its improvement. It is only, I may be a little conceited on this point, but it's only through the efforts, I think, of anesthesia, or partly or greatly due to the efforts in anesthesia, that a lot of types of surgery are being done because of the advances in anesthesia and because of the expertise of physicians in that practice of anesthesia has been able to help surgeons do what they're doing now, too. for example, open heart surgery and everything else that you can think of. I mean, it's all well and good to have a surgeon that knows what he's doing above on the patient, but on the other hand, you have to keep that patient alive. And that is a difficult problem at times. There are new drugs also that have come into play. I can't go into all of this, particularly because of the fact that I've been away from anesthesia, but I certainly know that some of the newer muscle relaxants, some drugs that are used to put the patients to sleep, all of this has improved and has changed over the time that I've been away from anesthesia, that again show advances in the various aspects of the drugs that they're using.
Would you care to mention some of the procedures and drugs that you used early on in your career that maybe still aren't in use today?
Well, I think there are two types of anesthesia really to speak about. One is general anesthesia and the other one is local type of anesthesia. When I speak of local anesthesia, we're talking about regional types of anesthesia. For example, spinal anesthesia, epidurals, and all the various blocks that can be done. For example, I had a carpal tunnel syndrome. Now, carpal tunnel syndrome is something that you do, that the surgeons operate on your wrist, and that was done under local anesthesia. All they did was just localize or freeze or anesthetize my arm and did the operation while I was awake. I mean, we did that when I was there too, but that's one type of anesthesia that's not changed. I mean, they're still using local drugs to do that. The techniques really haven't changed. The blocks were known at the time I was there, and they're still known now and used. General anesthesia, they still do the same way. You're still doing the anesthesia the same way, except some of the drugs are different. Okay. That's a change. But the techniques are the same.
Could you briefly describe attitudes towards smoking and cancer throughout?
Well, yeah, take it from a perspective in anesthesia. I smoked from the age of 16 to the age of 36, 20 years. At that time, I was practicing anesthesia, and I was seeing patients that I had to put to sleep who couldn't hardly breathe anymore, who were coughing and everything else. And I said to myself, what do I need this for? You know, I had a motivation. I could see what was going on with patients, so I didn't have to be told about the effects of smoking. I could see what it was doing, so I just quit smoking, and I've never smoked since then, since the age of 36, and I'll be 73 next month. But I keep telling. I have 7 children. And I keep telling they're all grown up and all married, etc. But on the other hand, I keep telling them there are 2 or 3 of them that still smoke a cigarette. And I try to teach the kids, that maybe it won't bother them right now, but as they grow older, they have a genetic factor they have to think about, number one, with me. And secondly, they have to think about what it does to you. And, I think at this point it's up to them to decide what they want to do. But on the other hand, they certainly have the experience and the expertise to tell them what this is all about if they care to. But again, you have to live your own life.
Right. So what did you really like about your practice in anesthesiology? I mean, what made you keep being a doctor in that field?
The thing I liked the most about anesthesia was the fact that I had time to spend with my family. As I mentioned before, I saw my family grow up. They saw me at home. They saw me as part of it on a daily basis, virtually on a daily basis. And this is something that I was able to combine a good life, provide for them, and secondly, I was part of that. So this is obviously what I liked about anesthesia a lot. It also gave me an opportunity to do a lot of other things too. For example, while I was in anesthesia, particularly while I was running the show at the hospital, I did a lot of research work on drugs, on many drugs, particularly drugs that were pain drugs. In fact, I used to go around, I did a lot of lecturing throughout the country, as far as California even, with pain medication, insofar as trying to help patients or help physicians understand that patients who were operated on had to be looked at in the postoperative period. I thought, and many doctors felt, that post-op care was not what it should be, namely that we should take better care of patients postoperatively and not just forget them. Now, I don't mean to belittle surgeons, but on the other hand, a lot of the surgeons that I know would take care, do a great job as far as the surgery was concerned, but postoperatively the patient was, was ordered something on a basis of give him something if he needs it every 3-4 hours or every 4 hours, and not looking on the patient to see if that was sufficient. And this is what I lectured on about, and this is the type of drugs that I work with quite a bit, in the sense that I thought we could do a much better job, that you had to see patients and you could not put them on a clock basis. You had to treat patients accordingly. That has been changed. That has changed. This is a great thing that's come not just from an anesthesia point of view, but also the pain clinic, in the sense that now we look at patients postoperatively. We have different techniques, for example. We can administer drugs on a time basis through an apparatus that gives them a certain amount of drug if they need it, not more than what they need, but on the basis that they need it. We can keep patients totally pain-free after surgery. I have seen patients when I was in anesthesia where they had chest surgery, and all we did is put an epidural in and kept them pain-free for 2-3 days, and their recovery was a lot faster. That's been proven to be a big boon in anesthesia and pain control. So I was involved in a lot of that. I did a lot of talking about that through the efforts of a pharmaceutical company that I was working for on the side, and spoke to an awful lot of physicians that way.
And you started your pain clinic, of course.
Yeah, and then it was a natural offshoot to follow with the pain clinic, too.
So do you want to talk about your practice in the pain clinic and what that was like?
That was a different experience in the sense that, it was one-on-one, obviously, just like any other physician. I got to treat patients, I got to help patients. The two sides to the pain clinic. One that is very gratifying, and I'll speak about that first. Number one, namely that whenever we were treating patients, whenever I was treating patients, particularly cancer patients, it was a very gratifying type of practice, because many patients who had cancer that I saw were not being treated very adequately. The my colleagues who were in general practice quite often were very shy for various reasons about using narcotics and using drugs of that nature. I know there was a legal aspect that they were worried about with good reason, and the fact that they were not trained in this as much. So that I had countless numbers of patients who were referred to me over the years who had a pain problem which was due to cancer or other diseases of that nature. And I remember many times seeing elderly patients come in and really cry because they could not get rid of their pain. And it was not unusual that I would tell them, give me about a week and I'll bet you that I can take care of that pain. And it proved to be so. Because, see, we were in a different situation in a pain clinic. I was visited by legal authorities about the use of drugs and so forth. But on the other hand, it was easy, I thought, to explain to them, to the authorities, that this was a different set of patients that I was talking about. And therefore, even if I was administering dosages of narcotic on a daily basis, these patients needed it, because the only way you can control pain is with medication or techniques of that, or other techniques. So from that point of view, it was gratifying to treat patients who had, particularly cancer patients, who were always very sympathetic and very happy that you could help them. And I did this, and that was a nice part of the practice. That was a good side. On the other side of the practice of pain clinic was that forever and ever we were being seen by patients who were just trying to find medication and abuse medication. So that's part of the practice that I did not like. And after a while, after all these years, 13 or 14 years I worked in a pain clinic, it got to you because you were always fighting that battle of keeping these people away. That you had to, some of them you had to control who didn't have cancer, mind you, and you had to keep on medication like this. But on the other hand, you know, it was a fight all the time to see and say, listen, I'm not taking care of you, or to be duped. Oh, don't get me wrong. Many times I was hoodwinked by patients that I thought were legitimate and turned out to be nothing but drug seekers. So that part got to be very tiresome and boring, and you were beating your head against the wall, and you got a little bit, how should I say it, a little bit burned out. I remember once when I first started, or even before I turned full-time in pain clinic, I heard one of the pain clinic persons give a talk to our group when I was in anesthesia. And he said one of the things that bothered him was that eventually most people in pain clinics got burned out. And that probably happened to me, so that by the time I reached that age that I mentioned and the times and the years that I practiced in a pain clinic, I had had it, and I didn't want any more part of it.
So there were people like that so often you just couldn't take it anymore?
Oh, there's still people like that. It's a fight all the time. I know of another institution that had a pain clinic and then eventually closed it because they were swamped with this type of patient. Mm-hmm. So, you know, that's a problem.
Overall, would you say you were glad that you went into starting this pain clinic?
Yes. I was very proud of that because, as I said, I started it with 0 patient, and it's still going today after 13 or 14 years from me and now 5 years out, and it's grown to where it is now, and they're still helping patients. Yes, I was very proud to have been part of that.
And of course, it gave you the aspect of being a doctor.
And yeah, and I had two sides of medicine. I had the sort of the technical, the technical non-patient relationship in a sense compared to the average general practitioner, and on the other side I did have this one-on-one with patients, and you know I did a little bit of psychology in a sense. You had to be a minor psychologist to deal with these patients with pain too, so that was another aspect that I enjoyed too.
I'm going to move on now. Over the years, how do you think Worcester is compared to other places in terms of providing care for the underserved?
I like Worcester. I've always liked Worcester. I came here at the age of 14 to prep school, and except for my medical school years and a 6-month stay back in my hometown, I've been in Worcester all my life. So I've liked Worcester very much. I think Worcester has been a great city. Unfortunately, it falls in the shadows of Boston, and anything that's not Boston is not as good as Boston. But on the other hand, I think it's a nice city. I think it's done a great job. I've raised a family here, and we enjoyed every minute of it. Now, as far as the background of the city is concerned, yeah, there's been a change in Worcester. There's been a big change, but I suppose you can say that about a lot of smaller cities too. The changes, obviously, when I first came here, and over the years, we did not have the numbers of minority in Worcester that we have now. That's not bad. I'm not saying it's bad, but on the other hand, that has been, I think, one of the biggest changes that I've seen in the mix of the population that Worcester has over the years that I've been here. I've been here since 1960, so it's been a good 40-some years now that I've been here.
What were some fears and concerns about socialized medicine in the 50s, the late 50s and the 60s?
Yeah, when I was practicing anesthesia, as I told you, we had this group of anesthesiologists called Western Mass Society of Anesthesia, and we used to meet at various hospitals from here, from the Worcester area, all the way to the western part of the state. And we used to meet at one of the hospitals every month, and we'd sit there, have something, we had something to eat. The hospitals most of the time would sponsor a dinner, and we would discuss cases. anesthesia cases, problem cases, and so it was very, very interesting. Unfortunately, over the years, this changed. And how did it change? We got to a point where we did not discuss cases anymore. All we talked about is about the government and finances, etc. It destroyed the group. We never met after that. After a couple of years of this, or 2-3 years of this, there was never, the Western Mass Society did not exist anymore. That was the unfortunate thing about it, and that brings us to what you're talking about now. I think what you asked is the question of government and so forth and finances. We spent our time talking about finances. Now, at the same time, while I was in anesthesia, or even before that, when I was a resident in Springfield, Massachusetts, the chief of anesthesia at that time told me, he said, look, Bob, he says, I want you to get involved in medicine. Get involved in your anesthesia society. So I became involved in the Mass Society of Anesthesiologists. I got to the point where I even became president. So I was involved for 20 years as a member of the Mass Society of Anesthesiologists, and most of the functions as an alternate director and everything else to the ASA, to the American Society of Anesthesia. And I fought the battles, and all we talked about was the government and the finances, etc. It changed completely. Now, so that after a while, after 20 years of that, I decided that I had enough of that, and I didn't bow out. Eventually, at the age of 65, I did retire from the society, and I'm an honorary member of the society after having been there all these years. But I would venture to say, even though I have not been active anymore, I do get some publications from the American Society, that most of the problems that they deal with now is government problems and financial problems. And medicine has gone that road. Inevitably, why? You want to ask? I'll tell you why. Because we have Medicare. Medicare started all that. And as far as I'm concerned, physicians at the time that the government promoted this program, physicians in general were not in favor of this. But it went through because of the public esteem for the need for Medicare. Now, I'm not saying we should not help people who need help. And it's a very tricky situation to be able to do above, you know, in a very good manner. But on the other hand, insofar as medicine is concerned, let me stay away from a minute from the recipient of Medicare, namely the patient. I don't want to talk about that right now. But as far as a physician is concerned, it put us in a situation where we were thinking, and as years went by, where we had to perform more and more government tasks, namely paper, 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 paper. Secondly, the government cutting back on the income and requiring more work to be done. Now, I know some of my colleagues, I know a very good friend of mine who's an internist, a general practitioner internist, who's still not involved with any organization. He's in private practice. Now, he works maybe 4 or 5 times more than he did years ago and is earning less, or just about as much. He spends all his time, and his income has been depleted by the amount of work that has to be done vis-a-vis the office work, the filling of forms, fighting for this and being told this. This man still does office house calls. He goes to nursing homes. So he has to go to nursing homes, and he has to go there, but he's only paid once a month, or whatever it is. I forget what it is. So the whole thing is just ridiculous. Most of the time that he is spending is involved not only in office work, but as much time just trying to cope with what he has to do from the Medicare point of view. Medicare has not helped physicians in that sense. Medicare has only brought out the bad physicians, too. There are physicians, like in any other type of practice, who have been involved in burglary, who have been involved in in fattening themselves at the expense of Medicare. You see that in a paper where some physician is involved with the government and being taken to task by the government because he's filed wrong forms, or not wrong forms, or multiple forms of wrong for all of this goes on. But this is something that obviously I don't think existed as much prior to Medicare than it does now.
Okay, well, obviously you've talked about the effect of managed care on the physicians, but how do you think managed care with Medicare and
Yeah,
Medicaid?
I think managed care, I don't have a problem with managed care. Some of the people that I know, colleagues that I know, you know, put up their hands in desperation and in frustration because of the fact that everything is run, practically everything is run now by Medicare, not Medicare, but by the government, and secondly by managed care and HMOs and so forth. The general practitioner is a dying breed. It's, you know, they have a very difficult time to make a living on their own and to exist like they did many years ago. So from that point of view, I can sympathize with the situation there. But on the other hand, as far as my feeling towards the HMO, I dealt with HMO when I was chief of anesthesia and the chief of the corporation at St. Vincent. Over the years, we dealt with them. I didn't have a problem. But again, what's happening with this situation is that each time that, with each passing year, what we see and what I hear is that they have to sign new contracts. They sign new contracts. They lower the reimbursement rate, and there's all heck to pay. I can give you an example of that right now, namely at St. Vincent or Worcester Medical Center. There was a great department of anesthesia. Now, lately, I think from what I hear, they had to sign a new contract with the corporation, namely Tenet, and because of that, half of the group has left. So, I mean, they just did not leave just because they didn't like to work at St. Vincent. They left, obviously, because they were displeased with the terms of the contract, of which I'm not familiar. But I would suspect that the contract was less than what they were used to when they were not under this particular contract. The same thing applies to, for example, to HMOs. When I was involved with the HMOs, I had to spend all our time arguing and discussing with the HMOs the contracts that we had with them. So again, I can understand where the HMOs are coming from. They have to produce, and they have to make the best of a business situation, but the same thing applies to the physician too.
So overall, how do you think the public's access to healthcare has been affected by HMOs, Medicare, Medicaid, and the government, really?
I don't know. Maybe from where I come from, I don't have the exact knowledge of that, but I don't think the public has been deprived of anything. I think the public still has access to good medical care, whether it's through an HMO or through any other organization. I think it's the HMO and all the others that are involved with this managed care, they're all involved in trying to give you, as far as I know, the best medical care for the best price. Now, as far as the John Q. public is concerned, depending on who he's working for and whom they are going to relate with as a possibility, he may be forced to relate with a certain group of physicians that he's not used to because of the way that because of the situation that he's working or the company he's working for. That's another problem. That I can't control that. But on the other hand, there are excellent physicians in all the HMOs that I know of, so I don't think that's a problem.
Oh, did you ever have any direct involvement with HMOs?
Yes, I told you that. As chief of anesthesia, I related with them when the Fallon Clinic started. For example, when the Fallon Clinic went into an HMO, I was involved with that. Can we turn that off a minute?
Yeah, sure.
What's the matter?
How have doctors' salaries changed over the course of your career?
How what?
Doctors' salaries.
Like anything else, they've gone up tremendously. When I started, I mean, I'd say compared to when I started, it's probably in a neighborhood of 2.5 times what it was, at least. See, we were all, as a group, I was working with a corporation. We were part of a corporation, so that, you know, I was paid by the corporation. But that same corporation, if that corporation existed today, and it does, or it did, and, you know, all things being what they are, the level of the anesthesiologist today has probably gone up 100%. But so has the cost of living. The cost of living hasn't gone down, I can tell you that.
Yeah. So it's all proportional.
Yeah.
How is malpractice insurance as well as its impact on doctors' practice?
Wow, that's a big thing. In certain fields of medicine, that's a big problem. In anesthesia, for example, I just read something that has gone up about 26% there lately. So that the cost of malpractice has been a substantial cost as far as anesthesiologists are concerned. It was worse than that for a period of time, but there's a new organization involved in anesthesia called the Safety Foundation, which has been started by some anesthesiologists that look just at the question of safety in the practice of anesthesia. And because of the things that they have done to promote better safety in the operating room, for several years the cost of malpractice has come down because the statistics were in that favor, that the practice has been much safer. For some reason or other now, and I'm not sure exactly of this, because again, I don't follow medicine as much as I do anymore. So that I think I know that in anesthesia, recently having read something, the cost has gone up, but I suspect that a lot of this is probably due just to the incidence of malpractice, but to other factors. However, again, you know, in this society that we live in is very litigious. They'll sue at everything. I don't care who it is, what it is, and therefore, how often you see in a newspaper or on the TV or any place, everybody's being sued for one thing or another. So medicine is a favorite sport to sue, because patients want. See, one of the things that patients don't seem to understand is that despite the fact that there's nothing wrong with the way a situation or a case has been treated, things can go wrong. I gave anesthesia to patients who were supposedly in very good shape, and all hell broke loose. Not because I did something wrong, but because the patient acted that way, reacted that way to whatever the reason was. So, you know, this is not acceptable to patients. Most of the time, you know, it's just another source. And then we have to blame also, I think, the other side, the legal side. The legal side is, there are more hungry lawyers around than there are hungry doctors, I think. That's for sure. With all these ads on TV that you see every day about, you know, do you know that you have a case if this happened, if this happens? Never mind the facts, but I mean, it's just looking for business, and this is in the minds of the John Q. public all the time.
I mean, there are lawyers that just specialize in
An easy buck if you can sue, you know.
So what do you like best about practicing here in Worcester?
Well, as I said, I like the city. I like the city. I like what I raised my wife and I, not just me, but my wife and I raised 7 children. They all went to school here. They all had a pretty good education. They went on to various colleges and universities. We have, they still, I think out of the 7, we have 4 that still live in the city or in the area, 3 that are a bit further away. But all in all, I like everything in the sense that we're situated geographically in a very good place. We're close to Boston. We're not far from New York. We're not far from the north, going up in New Hampshire. We're not far from Rhode Island. So it's ideal as far as I'm concerned. Without the bustle, when I go into Boston, for example, I came back from Northborough last night at 4 o'clock. Coming down Route 9 was something else. I mean, it's just unbelievable with the traffic and so on. People that have to travel like that every day, I don't want any part of it anymore.
So, what do you like least about Worcester?
Taxes, but unfortunately that's the problem with everyone. The taxes are very high, as you might have noticed recently in a newspaper. I think Worcester has a very good market as far as housing is concerned. The market is one of the highest in the country or the area. However, knowing that everything else has gone up, I think taxes for my own here have gone up about 300 or 400% since I've been living here.
Were there Worcester physicians that you admired when you started practicing here?
Well, we were a closed group. So as far as the anesthesia is concerned, yeah, we're a closed group. So the people I work with were like brothers as far as I'm concerned. On the other hand, I met a lot of physicians that I knew who were not in anesthesia. And there were several of them that I enjoyed very much, that I enjoyed working with. Unfortunately, many of them are deceased. At my age now, I see a lot of my colleagues that disappeared, so it's hard to say. But yeah, I had some good friends that were surgeons. I had good friends who were in practice in other specialties, so yes.
How do you feel the role of the physician in this community has changed over the years?
Well, I did mention that. We talked about the fact that I think physicians are much more involved or equally involved, not only in medicine, but in the politics of medicine. So.
Now, what were public perceptions of doctors like back when you started practicing?
Unfortunately, that has changed to a certain extent, not just here, but all over the place. I mean, doctors at one time were thought to be almost sacrosanct, but obviously that doesn't exist and probably should not exist. On the other hand, it's a very noble profession, and one that is still involves many physicians who love what they're doing and love to treat patients and help patients, whatever their practice is. So from that point of view, I think there's still some pretty good feeling. On the other hand, those who are not looking at that aspect of what a physician is like and what he does, but just look at him as an easy grab bag, that's another story. Physicians, because of the fact that the society that we lived in had lost a lot of the luster that they had because of what we mentioned a few moments ago.
How is women's health in Worcester changed?
Well, a lot more women. This started almost when I was in medical school. We had, at least in Laval, we had several women in medicine. Obviously now, I don't know what the situation is, what the statistics are, but a great number of women are involved in medicine, like they are in a lot of countries. I think this was much more prevalent in Europe than it was here, Europe and other countries. But on the other hand, in America, in the United States, this has become a situation where I think it's on an equal footing almost. I don't have a problem with that.
How did group practices or hospitals treat minority physicians early in your career?
I never had that problem because in my group of anesthesiologists, there were 2 or 3 Indian fellows that we had as equal partners. So I never had a problem with that. Now elsewhere, I can't speak for general practice. I can't speak for medicine in general. But yeah, there have been some areas where, for example, even in anesthesia, for a while, there was a great number of foreign students who came into anesthesia. Mainly, I suppose, because there was a need for it, and number 2, it was enough to get into the residencies. That changed over the time. so that you know, there's some qualifications that foreigners have to get into this country to practice medicine, or to come into study medicine for that matter too. So that has changed, and that has limited the number of foreign students. Some of the practices have seen a decrease in that, others have not. I think there's room for everybody. I don't think that's a big problem as far as, I don't see that as a big problem anymore. I think it's a matter of choice as far as the patient's concerned. If the patient has a problem going to see someone because he's not a white Anglo-Saxon, that's one problem. That's his problem, not everybody else's problem. So.
Well, do you want to go back and talk about maybe some stories from med school or your residency? Or we haven't talked about your military.
Yeah, med school is interesting in the sense that I went to Laval University in Quebec. That was French. They taught in French there, but all our profs knew English as well as French. The fact that I was an American, I could take all my exams in English. So I never had a problem with that. But to sit there and be the only American, in my class I was the only American among Canadian students, that was an experience, to say the least. I learned to keep my mouth shut too much. But I swear at times that when I got into the oral part of my exams that I baloneyed a few of my professors by doing them in English. But anyway, that was something different.
How about your residency? You want to talk about anything?
Residency was not a big problem. As I told you, I enjoyed the residency in Springfield, Massachusetts. I was treated very well. I think I learned something, but I learned a lot more when I got out of my residency, I can tell you that. No matter what you do in your residency, when you come out into practice, that's a whole different ball game. So I had no... I was very much involved even as a resident in the society work. I got to be very active there. And, you know, from that point of view, I was very happy that my boss showed me that road. I enjoyed every minute of it.
Now about your military service, we haven't really...
Oh, well, it's one thing, and maybe we can almost end with that sooner or later. I have to, a couple of things that I have to do. But yeah, when I was in my medical school, that was prior, when the Korean War was going on. And they were still drafting. I still had a draft status that was deferred while I was in medical school. So when I left medical school and went into my residency, I continued being deferred on that basis that I was still, I could become useful to the Army or to the service after I finished. At that time, I had a choice of joining the Army, Navy, or Merchant Marine or something. I don't know what it is. So I joined the Army. I was commissioned a first lieutenant in the Army. What I did when I got into my residency in Springfield, I was a first lieutenant, and I had to go and do some reserve duty on weekends, and once a year, I used to go up to Camp Drum in New York and do 2 weeks over there. As I was promoted to a captain, and then when I came to Worcester, I was involved with the group here in Worcester, which was a subset or subsidiary of the General Hospital out of Boston, the 803. So I was the commanding officer here in Worcester, the medical detachment. At that time, we got the Cuban crisis came up. And I was involved in that in the sense that we were told to stand by, we were going to get activated and so forth. That fizzled out. So from that point of view, I stayed in the reserve. Once I finished my residency, even before getting into practice, I wrote the Surgeon General and I asked them where I would go when I finished my residency. And I was hoping to go to Europe because I always wanted to go to Europe. I got a letter back saying that once I finished my residency, I would receive a letter from the government or from the Army telling me where I would go. When I finished my residency, I got a letter saying that this was the last year of the Eisenhower administration where they were getting rid of a lot of personnel. They told me they did not want me in the Army, that I could join the Navy or the Merchant Marine or something like that. I said, baloney to that. I don't want to join the Merchant Marine. I don't want any part of the Navy. I want to stay on land. So I served my time out in the reserve, and at the age of 35, I was discharged after X number of years in the reserve.
Okay, well, I just have a couple quick questions left.
Yeah.
With medicine being such a changing and growing field, how have you found yourself keeping up with the changes in
I don't.
education? Really?
I don't. When I left medicine, I left completely everything about medicine aside. I got rid of all my books. I read nothing about medicine. I'm just enjoying life.
How about during your career, like right after medical school, how did you keep up with the changing education?
Well, I was involved with, as I told you, with the society for a long time. I went to annual meetings for years and years and years. I went to refresher courses. I did that all that for about 20 plus years, 25 years.
And lastly, what advice do you have for younger doctors?
Well, I've been involved with younger people in the last few years in medicine, and I think young people go into medicine with a whole different idea than when we went into medicine. When I went into medicine, I looked at it as something that I could do, but that I would be a private practitioner. I don't know if kids look at it today, because I know what they're faced with. That doesn't hardly exist anymore. So are they ready to join a company, which is what it amounts to? Are they ready to be employed by somebody? Is that what they want? If they want that, fine. And I presume that most of the students are involved in that sense and accept that. That's not what I wanted. That's the big difference in medicine today. I think as far as if you're a younger person and you look at it, if you're old enough to look at it in that sense, that this is a whole different ballgame. I never wanted to go in. For example, I told you that when I went into medicine and into the practice of anesthesia, I wanted no part of academia. Now, if you want to become an academician, that's fine. But this is not my thing. I wanted to become a private practitioner, and I did that. On the other hand, today, general practitioner, private practitioner is a lost person.
Yep.
So if they're ready to look at it this way, and I'm afraid that's the only way they're going to look at it, fine. You can still be a damn good doctor and practice medicine in any company or any HMO or any other one that you want to. But you also have a political problem, and you also have a boss problem over you all the time. And that did not exist when I was young.
Well, thank you very much, Dr. Ouellette. That brings us to the end of our interview today.
You're welcome.